Maybe you're an inpatient doctor, or you're in a hospital and it doesn't impact me. I don't write for these things on discharge, right? Well, I'm here to tell you you're still part of the problem. Because when a patient complains of pain in the ICU, do you give them morphine and Dilaudid, or do you give them Tylenol, Motrin, and ice? The quickest route to how can I get you to shut up, right?
Dilaudid IV.
Dilaudid IV. It's the PEZ dispensing of the unit. And now, in one version, we're trying to do less sedation-heavy, ICU vent management. So we're going to analgesic, opiate-based, narcotic-based sedation. So now we've got everybody on fentanyl drips in the ICU because we want to use less propofol. We know this stuff does not attack you and make you an addict solely because of a weakness of your character and of your soul. You are not a bad person because you're addicted. It's because it makes a physiologic change in your body. And the greatest study that was done in women that got hysterectomies. And they looked at this group, and they gave one group intraoperatively Toradol, which is super Motrin, and one group fentanyl, which is a strong super opiate. Double-blinded, so nobody knew what they got, and they gave both sets of women PCAs, the buttons to push to give themselves more narcotics. And the group that got the Motrin intraoperatively used half as much opiate as the group that got an opiate intraoperatively. That isn't an evidence that it's changing us on a physiologic level. And our perception of pain, I don't know what else is. So when we choose to put people on fentanyl drips, so we're using less propofol, yes, it's maybe making their sedation score better. We've treated their RAS, if you follow their literature, and we've made their numbers look better, but that's better in the ICU. Is that better for their long-term health care? I'm gonna argue no. And how many of you are thinking, well, they have real pain. They're a trauma patient. Yeah, true. But did we start with Tylenol and ice? It's only for a few days. Well, again, 3 days, 5% risk, that first prescription. I don't have data for what it is in-house, but I'm gonna bet it's equally as much, if not more. When it's up to the next unit, the next doctor, et cetera, to wean them off of it. Well, once you've created the addiction, or the tolerance. Use the language you want, but either way, we've created the problem, and if we can go upstream again, just like in our discharge prescribing, and stop the initiation, reduce the initiation in the ICU, and have that conversation to change the culture up front, then we can do the right thing. So I'm going to give you my brief answer on is failure an option, and Jeb's going to go into detail about why failure is not an option. And it's no, because A, it's the right thing to do, and that should lead us. It's self-policing rather than Big Brother, which again is the right thing to do and is the only way it'll work, but there's always risk. It's education, it's not punitive. And failure will lead to many, many, many bad ideas to come out of Olympia. No offense. So mandatory PD&P checks, screening every patient, informed consent forms, and more paperwork. And did I mention prior authorization? I mean, seriously, really bad ideas. Jeb will explain to you all the bad ideas. The good idea we're hoping for to come out of there is funding to run the program. Funding to run the program. Take notes, so noted, okay. I hear a second, no. Key numbers. Maximum pill count for those that are under 20. What is it? 18. Maximum pill count for those over 21. 42. Risk of ongoing opiate therapy in a year with even 7 days of scripts. About 10%, yeah, 12%. So if you can remember those numbers, it changes the conversation. And the other one I use is 75%. 75% of all opiates that people use in the past year came out of a medicine cabinet from a friend or relative that they bought or stole it from. And so I tell patients that, I had a very nice, wealthy woman in my ER the other day who had a little DVT, and she's like, the pain's unbearable, I need something for it. I said, okay, I said, you've got a real problem here. I said, I just want you to understand that if we write you for Vicodin, there's a 12% chance you'll still be on this drug with the debilitating constipation and life threat that goes with that in a year. And there's a 75% chance that that's where the drugs will come from that your kids get addicted to. She said, well, that's really depressing. I said, truth hurts. So my patient stat scores probably went down on that one, but I work in the ER. So in conclusion, we as providers and as those that care in this community really have to address this issue. We have to lead on it. We need your help to do it. We can't do it from just the WSMA or the Hospital Association. And we've got to change the conversation in communities. If nothing else, the next time your friend comes home from the ER, from their family doctor, says, all they gave me was Motrin, hopefully your answer is, well, it sounds like they really care about you because they're not giving you the good stuff. These are my tiny terrorists. So in the end, this is really touchy now. To close with my dear friend, Mr. Rogers, the really important great things are never center stage of life's drama. They're always in the wings. That's why it's so essential for us to be mindful of the humble and the deep rather than the flashy and the superficial. I say that because at the end of the day, this work is not what goes on billboards. This isn't the work that goes in your advertisement out to your consumers. It's not going to be the thing that makes it on CNN, more likely than not. But it's the stuff that I think really makes a profound difference in the lives of our patients. And if we can drop opiate prescribing 60% in our state, I really truly believe we can make a difference in people's lives. And it takes education, feedback, and participation, and it takes the community changing its ways. So it's not going to be flashy, but it could be great. And I appreciate your time. We can do questions now, or we can dive into the next two presentations and come back.
Should we open it up for questions?
And I made it 2 minutes to spare. No questions? Come on, somebody wants to argue. There's a surgeon out there that's itching to prove me wrong. No? Yes?
I have a question with this. My name is Lisa. I'm from Seymour.
Hi, Lisa.
I'm just wondering if there are any
Seymour.
studies with the opioids with veterans, because I know that's a high population group that seeks opioids.
Well, and they have a huge overlap with mental health. Back to our self-treatment of mental health, 50% or so are also substance abuse self-treatment. So there is data in the veterans population. I don't have the exact numbers, but yes, there is a crosswalk and a correlation there. We know they have higher rates of PTSD, higher rates of opiate dependence and all forms of dependence, unfortunately. So, and we know they commit suicide higher than any other group, especially in Washington State. So yeah, high-risk population.
Thank you.
I'm asking about the palliative consumption.
Yes.
I mostly see old people
Uh-huh.
that aren't operative candidates and have broken down spines and such, warfarin.
All old people are not palliative candidates.
Well,
Patients.
how do I help the person that can't sleep
Yeah.
and needs, here's what happened to me, I'll just tell you the story. Old lady, bad spine, puts up with her pain all day long but can't sleep.
Yeah.
I write her a prescription for 30 sustained relief morphine, 15 milligrams at bedtime so the poor soul can sleep.
Yeah.
Insurance company won't pay for it. Exceeded the 7-day amount. Can I write palliative on that thing? You know what I had her do? I had her pay cash.
Yeah.
Here's my partner in my practice. Similar scenario. You know what she did? She said to the patient, now you just take this at bedtime, but here's 42.
Yes.
I applaud this work more than I can
Yeah.
tell you for acute pain. It's making it hard for the patients and for the doctors that take care of old, sick people that we can't fix.
Yeah.
Any advice for me?
So what I would say is that's not actually this program. If you're just doing one tablet at night, you'd be 30, you'd be under this. And the other thing I'll tell you right up front is there's an easy way to cheat, which is write one for anything under 42 and then one immediately following that for the next day.
I don't want to have to do that.
I know, but I'm just saying, even if this were the problem, there is a workaround. But the one at night is not under this program. That's under the insurance companies like Molina and their crazy plans.
Well, yes.
Not to name names, Molina. Hey, oh, darn it. I know. I got to have, plants in the audience, Yeah. No,
Fabulous work.
Yeah. No, and that's the thing. That's part of the reason we didn't want prior authorization was because I agree there are exemptions, and that's exactly what we want to do because 0 is not the right number, and 100% compliant is not the right number. Right. And that was one of the things when we were in the legislature talking about this. I said, look, our first cut of data, we're at 80% compliance, and they're like, well, that's a horrible grade, and I'm like, except for 100% is not necessarily the right answer either. We don't know what the right answer is. What I can say is the variance should be a lot lower. It should look like that great department that had 13 as their highest and 0 for most of them. We got to get rid of the 25 to 100 spread. So it's like, let's work on that. Let's do education. Let's do feedback. Let's make people buy into it and not put those type of prior authorization and payment limits on it. And it is. And so that's why we did this. That's why I run around and do this throughout the state and hopefully get more systems to join is because It works. It worked. We saved tons of money. We saved tons of opiates in the state when we did it in the ER. We're going to do it again statewide. It's just, can we get it done fast enough as the House of Medicine so the legislature doesn't solve it in their unique and horribly painful paperwork ways?
I just want for the record,
Yeah.
there's some fallout that
But I'm hoping if we get this under control, maybe we can roll back some of those prior authorizations. And then, we're working on the WSMA, and Jeb can talk more about this on kind of the gold carding idea. And if you're approving 99% of all prior authorizations, maybe that shouldn't be a prior authorization, right? Like they're just like your CMS grades. If you're 99% compliant with CMS's quality metrics, you no longer can use those the next year. You graduate out of them. And nationally, emergency medicine graduated out of almost all of our metrics. So we were not going to be able to qualify for MIPS for 1 year, but we built some more. But so, it's like you should be able to graduate out if you're doing a good job, is my summary. And so hopefully as we fix this, we can fix that. But don't blame me, blame them. That's the summary. Other questions?
I have a question, I think, or comment. I'm very fascinated by the work that you guys are doing.
Yeah.
And it's almost like a precursor to prevention, right?
It is prevention, yeah.
But it's a precursor too, because rather than to prevent, people's addictions, we're preventing or managing the prescription of those things that lead to addiction and so on and so forth.
Well, and the first prescription carries that 10% risk. So we're doing prevention by not loading the gun.
No, I'm very
Yeah.
congruent. I guess I'm just explaining it from my lens.
Yeah.
Which is the opposite of what led us into the crisis, which was the miseducation about that this drug will not cause us problem. You're saying, no, they do, and here's the evidence. So let's use our science. We're doctors, we're the highest educated guys in the room. Let's use the sciences to mitigate this. What I didn't hear you say one word about sort of the behavioral health sciences and how can they interplay in these processes. I happen to be very passionate when people, leave the ER or they have a, physical situation, and then, okay, this is the minimum medications I'm going to send you, but and then what other alternatives, some physical therapy,
Yeah.
Maybe a behavioral health specialist who can help you mitigate some of your environment and your household, or how to deal with pain better.
Yeah.
I didn't hear you say much of that.
Yeah, and that focus on this is on acute, that downstream, that chronic management. I think you're hitting all the right keys. PTOT, again, prior auth is a huge barrier, especially in the Medicaid environment, to that. Massage chiropractic as well. I actually believe in chiropractic for curing musculoskeletal ills. They're not going to cure cancer. Sorry if that offends anyone. But they're great for musculoskeletal issues, and getting that out there so that patients can get access to that. Right now it's very, very difficult, especially in the Medicaid population, to do that, but so critical. And that's really the next phase, I think, as we move from the acute prescribing into the chronic management and then into treatment. If you've already got addiction, it's not just don't take it, we're not prescribing it, and don't do heroin. It's let's get you on Suboxone initiation, and let's get you to PTOT and the behavioral health counseling, because it's not just one piece.
Right,
You're right.
I see that as an important part of the prevention itself, because after all, even if people have some level of discomfort, or a scale of 1 to 10, still I heard 4 or 5, well, I still heard,
Yeah.
and I would like you to advise me, how can I do this,
Yeah.
or at least guide me to the right resources so I can get my optimum.
And we're getting there. It's, that leads into a lot more tough conversations because, your back is injured. It's often lose weight and do sit-ups, which, they're already mad that we didn't give them narcotics and now I called you fat. It's like, it's a twofer on really killing your satisfaction score. I'm going way down on this one. But, that is one of the things that we're getting to, is kind of back to that social determinants of health.
Correct. One last question. So
Yeah.
the hospitals that you guys are sort of enrolling in this project, you guys also providing all this wonderful information, follow-ups, explaining why the data moves, different type of conversions and information along the way?
Yeah. We're doing it in basically two levels. We're giving your entire health system's data to a thought leader, generally a CMO of a health system. And then we have also taken on the administrative burden of we send the individual reports to the individual providers directly from the WSMA. So we know that you as the doc gets where you're at, and you get everybody in your group of family medicine, emergency medicine, so you can compare you to you. And there's a slightly different letter that for if you're a high outlier, in the middle, or low. So you get a different letter that says, thank you for your attention. You're prescribing more than one standard deviation above your peers. We encourage you to look at the guidelines of 18 and 42. And some of them are, as with all these types of programs, even my health system, as soon as I started narking on the primary care and other groups. Like, well, we can write better reports. I said, great, you should do that. Until you do, we're going to keep sending them. It's kind of funny. It's like, it's getting that shared community movement around it. So,
Thanks.
yeah. Yes, ma'am.
When did you first start sending out these letters?
To the systems that are involved, we did our first quarter out in April.
Okay.
So March or
And,
April.
what are the key data pushback that you've gotten?
Mhm.
People complain about the data all the time, but
Uh-huh.
what are the specific issues that they're complaining about, and how have you addressed those?
Medicaid only. So yes, it's Medicaid only. We hope to expand to all payers with Department of Health in the near future. But one of the things that with any program we find is perfection is the enemy of progress. And so we just said, we've got something, and when DOH is ready to step in and actually do full all prescriber payment types, PDMP data, we will gladly convert tomorrow. I have no allegiance to Medicaid data. They just actually had their act together. We had worked together before on the ERs for emergencies, so we moved. And because I want to get moving. I'm an ER doctor, I have mild ADHD. So the second complaint is, well, there aren't that many prescriptions for me in there. It's not fair. I don't have a good data set. And my answer to that is, yes, if you only have one prescription, that's a fair criticism. If you've got 25, that's not a fair criticism when your colleagues have 25 and are at 2% and you're at 100%. And the third one is, I'm a snowflake, I'm special. And my answer to you is, super, look at your snowflake status versus the people in your office because you see their names. If you and Dr. X do the exact same surgery or take care of the same type of geriatric palliative population, and they're prescribing 100% compliant and you're 0% compliant, why don't you walk across the hall and ask them? And so it's prompted some conversations. So I get intermittent hate mail in my inbox, and I respond to it all because it's just entertaining. So I have a good dialogue going with a primary care doctor right now, back and forth, and he's like, but he started to catch on. He's like, he had ignored it, thinking, he's following the guidelines, and he wrote me yesterday and said, well, I had a patient that I actually sat down and calculated her morphine equivalence. She was at the Seattle Pain Center, and I was embarrassed at how high it was. He said, but now what do I do? And so we talked about tapering and other things. So those are probably the big three we get. Yes?
I'm sorry, I got up so late. Did you
You're fired.
talk about the Suboxone problem in terms of the medication, the morphine equivalent dosing?
We didn't talk about Suboxone. We're focused on acute today, but there's that back end of getting more MAT out there, and Suboxone is part of that.
Yeah, just because I was one of the people who got a report, and it makes your MEDs look super high if you're a Suboxone provider.
That's not my reporting, that's DOH's reporting. Blame them. How's that for an answer? So we're looking at acute prescribing, and Suboxone and methadone are explicitly excluded from the data set. So yes, and so I really believe in as much data pure as we can, and so that's where I'm an ER doctor, I'm in the KISS principle, keep it simple, stupid. And so it's like, look at the behavior you want to change. So the 3 behaviors I want to change, if I'm being completely transparent, is less pills per script, less number of scripts. If they're on chronic opiates, then no benzos and sleepers with them. If we could do those 3 things, we could knock out a decent chunk of the problem. So how do you get metrics that fit to that people believe? Well, we've got guidelines on what acute prescribing is, 18 and 42. That'll push down those higher numbers. If we're looking at lower script numbers, we're trying to find a rate control. The challenge, like I said, is right now with Molina data and all the MCOs, the way they feed the data in, it doesn't label it to us as providers. It just says, you saw CHI Franciscan, which doesn't help, unfortunately, for being able to do a rate comparison of how often I write versus you write. But you can do that at your individual system level, and that's what I've got for my people and what we're building for all the other parts of our group. And the third question is, how often do you co-prescribe? And that's an easy report to run out of the state. So that's probably the next one we're going to do, and leave the middle question for when we can get better data science. But pick the metric that you can move, that you have reasonable belief in, and the behavior that you want to improve. Don't just put out pretty metrics that don't matter. So like one of the ones I pick on all the time for the BRE is they've got this lovely, morphine equivalents a day. What's your average morphine equivalent a day? Well, what are you supposed to do with that data? Because if you see all the geriatric old people and you're writing for 20 morphine equivalents a day for 1,000 people, are you more of a problem than the oncologist who's writing for 1,000 morphine equivalents a day for 5? Which one's the problem? What do I do with that data? How do I respond to that as a clinician? What's the right answer community norm? And I don't know what that is, therefore it's data that doesn't mean anything to me. And so we want data that actually drives behavior change. So that's why we picked this metric. But there are lots of other ones out there that are not us and that we can go look at, but I'd really want to clean up that data, and that's a great example of the problem. Yes?
Yeah, good talk.
Thank you.
A hypothetical.
Hypothetical. I love hypotheticals that are based in reality.
Yeah, so given the culpability that we docs had in creating this problem, have you, as you're sort of reflecting on it, doing internal discernment about how we got here,
Yeah.
is there something analogous to opioids that we're doing right now
Oh, yeah.
that a couple decades from now we'll look back on and say, well, we screwed up again?
Yeah, most of the things we do in hospitals. No, I mean, seriously, I mean, if you go back and step back, there's data around cardiac caths and cathing non-STEMIs. The HOPE trials and others that have really said, we shouldn't be cathing non-STEMIs, yet show me an institution that doesn't cath a non-STEMI. I mean, my father-in-law got a cath for his non-STEMI. So there's lots of data out there of things that we do that are at the margins, fourth, fifth, sixth, seventh line oncologic drugs. There's data out there in the palliative care world that you will live longer on palliative care than nuking every last remaining cell that you have. And it's like, we do these things because it's a hard conversation to have to say no, just like the opiate conversation and say, death is a part of the human condition. None of us make it out of this thing alive, right? We don't have those conversations. Opiates is pain is a part of the human condition, and yes, we can help, but the answer is not no pain. And so those same conversations, yeah, there are a lot more things that we're going to do. And as we start driving, in theory, towards quality, that's what we need to get to. Those are just really, really hard things to do in large data set metadata aggregation. So it comes down to the individual conversation. I chair our peer review committee for our health system for all specialties. And we had a case recently that I was way out on the limb on the wrong side of, from their perspective. But 89-year-old woman with a pessary that smelled infected. And so the outpatient doc admits her to the hospital for 3 days to await her culture results and start on high IV dose antibiotics. And the reviewer thought that was a concern and sent it in and said, opportunity for improvement. The rest of me said, no, if we had not admitted her and she had turned septic, we would have been in trouble. I said, but admitting her to the hospital is dangerous. No, it keeps her safe. It's like, no. You admit somebody above the age of 80 to a hospital, the likelihood of going home with an ADL impairment is about 75%. The likelihood of going to a nursing facility is about 25%. And this lady tried to become one of those statistics because she fell and hit her head in the damn hospital because she got confused in the middle of the night as an 89-year-old woman not in her home. So I'm sitting there going, on a population level, this is the wrong answer. I understand it's the right thing for us as physicians in one sense, that it keeps us safe from a medical legal standpoint. It's not the right thing for the patient. And so as we start getting to that shared decision-making conversation, I think we're gonna find a lot of those things that are very uncomfortable. And the rest of the committee thought I was nuts. And so, I went along with the committee, but I was like, look, I don't think it's the right thing to put Grandma in the hospital. She had normal vital signs, she wasn't septic. If you want to feel better, do an ultrasound and prove she doesn't have a boggy uterus. I don't care, but don't just say hospital safe, caths are safe, 7th round oncology drugs are safe. There are a lot of things we do that are not safe because they're the historical answer and the conversations are hard. And opiates is one of the first conversations around this, but I think we have a lot more of those to go as we drive towards making better health and really driving towards population health and really saying, and by the way, your health has very little to do with anything that we do, right? 80% of your health is what the decisions you make in your life. Do you smoke, drink, do drugs? Are you obese? Do you manage the health conditions that you have? Do you live in a food desert? Are you homeless? Those aren't things I can fix. As an ER doc, I see you when generally all of those things are really, 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 really broken, right? So we're cleaning up life's choices. And we've got to talk that conversation and say, your solution to your diabetes is not metformin at 400 pounds. Your solution is to lose 200 pounds, and then we'll see if metformin is the answer to the question. So all those types of things, are they black and white as opiates are? No, but I don't think this is black and white. There are times that are appropriate. So all those hard conversations are the things that I think we're going to look back and there's going to be the next epidemic. I might pick obesity as my next big epidemic that I think in treating of diabetes with pills and how we've let obesity run wild in this country is probably the next one. And I say that as a guy who weighed 50 pounds heavier when I was hanging out in the legislature with Harris back there. So, my simple life choice, commit to wearing spandex in public and doing triathlons. It's a great weight loss strategy. So, all right, I've eaten into Jeb and Trish's presentation, so I should shut up now and let somebody else talk.
If we want to sign up, where do you want us to, how do you want us to call you?
Jeb@WSMA.org, Jeb@WSMA.org. One-stop shopping. He's the Jeb exclamation we like. Man, not enough politic people here.